Hey guys, welcome back to USMLE question analysis. We have got ourselves another USMLE Step 2 or Level 2 question, which can be used for Step 3 or Level 3 as well. So we got ourselves here a nice long vignette, and we're going to start like we always do with kind of the question stem or the last sentence of each question. Which of the following is the most appropriate next step in management? Okay, kind of scan the answers. Okay, so it's a management question. So understanding what's going on, how sick the patient is, what they look like is going to be really important. So we have a 16-year-old boy is brought to the ED because of a 2-day history of fever, nausea, vomiting, headache, chills, and fatigue. Okay, so it sounds like this guy's got a 2-day history of some sort of infection, based on fever and some of these kind of constitutional symptoms. Hard to say exactly what type of infection this is right now in this first sentence, but it sounds like he's not doing so well. 2-day history, the time course is always very, very important. Is this an acute, subacute, or chronic kind of issue? This looks like an acute issue because it's only been going on for 2 days. So this kind of fits with our infection kind of theme here. He's not had any sick contacts. When I see this, sick contacts, you're thinking about the kinds of diseases or infections or illnesses that happen in places where people are in close contact with each other. So I want you guys to think of the kind of infections that happen in close quarters, like college dorms, okay? Places like prisons, places where a lot of immigrants are living, 5 or 6 per room. So close quarter types infections. In the acute setting, you could be thinking of things like Neisseria, that sort of stuff. But they're saying against that. They're saying, hey, no sick contacts. He underwent splenectomy for traumatic injury at the age of 13 years. Okay, great. So now we're saying this guy is a 16-year-old kid with an infection, and he's had a splenectomy before. Splenectomy tells me that he's immunocompromised. Okay. Next sentence, he has no other history of serious illness and takes no medications. If you guys want to pause for a second and think of, if we just go back to that last sentence, what does splenectomy put you at risk for? So what type of infection does splenectomy put you at risk for? So just think about those infections. Next sentence, he appears ill. Great. He looks sick. We kind of assume that. The vitals are really, really important here in management questions, okay? So when they ask you next best step, looking at the vitals is extremely important because in real life, this is how it's going to be. When a patient comes in and they're vitally very, very unstable, that's going to determine what you do next, okay? So his temperature is 39.2, so 102.5, right? A true fever is at 100.4 Fahrenheit or 38 Celsius. Pulse is 130, so he's very tachycardic. Respirations are at 14 a minute, and blood pressure is 110/60. So he's normotensive, he is tachycardic, and he's febrile. So tachycardic and febrile, this really fits the picture of infection, okay? On pulmonary exam, scattered crackles are heard bilaterally. Abdominal exam shows a well-healed midline scar and mild diffuse tenderness to palpation. Which of the following is the most appropriate next step in management? So when you have, right now we have got a condition called sepsis, okay? And this is something you guys will learn in clinical medicine. Sepsis is essentially when you have your body overreacting, and, having crazy abnormal vitals in the setting of an infection, right? So tachycardia, fever, sometimes you can be tachypneic, and then the last kind of measure is the white count, which you'd see in labs, which we don't have. But he's got sepsis, okay, which means he's got some sort of infection. Now, what's the source of the infection, right? What's the source? So in my head, I'm saying, well, his symptoms are nausea, vomiting, headache, chills, and fatigue. Like, okay, Could this be a meningitis? Possibly, right? Nausea, vomiting, headache. But nausea, vomiting, chills, fatigue, those are all pretty non-specific, and headache as well. So physical exam is really going to help us. When I hear scattered crackles are heard bilaterally, okay, something is going on in the chest. So is this possibly a pneumonia? So in my head, I'm thinking this kid who has a history of splenectomy is coming in with a 2-day history of, infection has led him to have sepsis, and now, which is likely secondary to pneumonia. The rest of these symptoms are kind of just, you get nausea, vomiting, chills when you're sick. Not that I think this is a primary GI bug necessarily. Okay. So which of the following is the most appropriate next step? So if this guy has got a bacterial infection, A seems like the obvious answer choice here to start antibiotic therapy. For the people doing, step 3, level 3, they'll ask you what exact antibiotics to give. But for even some hard step 2 questions, they'll ask you which antibiotics to give, and we can go over that in a second. Antiemetic therapy, like this is probably something you would do if he continues to have nausea and vomiting, but really, when you see a most appropriate next step question is, yeah, you'd probably do both. But, the way you got to think about it is if I give, one answer over the other, what that means is if I give antiemetics now, I can't give antibiotics for 4 or 5 hours. That's how you got to think about next best step questions, right? It's like, obviously I would do both, right? But okay, well, if you give antiemetics, are you going to hold your antibiotics for 4 hours? No way. Okay. CT scan of the chest. I think this is also a pretty good answer choice, but it doesn't take precedence over antibiotics, right? This guy is clearly septic. He's febrile. He's tachycardic. We think the source is the chest. Now, I would probably get an x-ray of his chest before I got a CT, and if I couldn't see anything specific, maybe you could consider getting a CT, but you would probably start with an x-ray first. Okay, so that's why CT is out. X-ray of the abdomen, X-ray of the abdomen is kind of useless. X-ray of the abdomen, the only real things you're going to see on the USMLE or levels that are going to test for X-ray of the abdomen are going to be, free air under the diaphragm. So someone's got like a perforated ulcer or something like that, and you want to see free air quick, X-ray is useful. X-ray of the abdomen is useful. And then E is out, reassurance. When you see abnormal vitals like this, reassurance is out of the question. Okay. So just a quick couple of learning objectives here. Recognizing sepsis and an infection and understanding that, hey, this is a bacterial infection. There are a lot of different definitions of sepsis. The one that most old school doctors will use is the SIRS criteria. SIRS just stands for Systemic Inflammatory Response Syndrome. So your body kind of overreacting or reacting appropriately, really, to what's going on in this infection. So they would have a leukocytosis or a white blood cell count greater than 12,000 or less than 4,000, or 10% bands. We didn't have those labs here today. On the vitals, you would see a heart rate greater than 100, so tachycardia. Tachypnea, this is something you guys that doesn't make as much sense in questions, but in clinical practice, you'll start seeing it. When patients look sick, they're breathing fast. And then a fever. So fever or hypothermia. So greater than 38 Celsius or less than 36 Celsius. So if you have 2 out of the 4 of these SIRS criteria, and you have a source of an infection, that's what we call sepsis. Okay. So just understanding, bacterial infection, sepsis, that's like the first basic learning point. Now, recognizing that pneumonia is a primary cause, and it's interesting because they give you fever, nausea, vomiting, headache, chills, fatigue. a couple things go through my mind here. Is this pneumonia because of this crackles bilaterally? When someone says fever, headache, nausea, you should be thinking about meningitis as well, but they don't really mention anything on exam about a stiff neck, any of the meningitic signs like the Brzezinski sign or the Kernig sign, which they don't necessarily have to, but just to sell their case on what exactly is going on. So my assumption is that this is pneumonia. Now, what the other learning point here is that him having a splenectomy makes him immunocompromised, right? So this question is kind of easy, and they told you straight up that he had a splenectomy. But for some of these patients, they would have said, this is a 25-year-old patient with a history of sickle cell disease, and he's presenting exactly the same way. And the extra step would be for us to realize that, hey, he's 25 or 30 years old. His body he's already kind of had an autosplenectomy, which means that spleen is just essentially atrophied because of his sickle cell disease, and he no longer has that kind of protection against those certain organisms. So that would be a quick way to think about, or an alternative kind of question that they could give you is a sickle cell patient presenting like this, a 30-year-old, and them having you assume that, hey, it's one of those immunocompromising type infections. So the types of infections that happen in patients with splenectomy or sickle cell patients as well, the mnemonic I remember from first aid many, many years ago is SHIN. So this is S is strep pneumonia, H is Haemophilus influenzae, N is Neisseria, meningitis. So these encapsulated organisms is how you'll remember them. But the encapsulated organisms are, this patient is not protected against if he wasn't vaccinated. So the next thing is, the way they could spin this is they could present this exact same thing, and they can say which of the following vaccines could have prevented this condition, right? So essentially they're saying a guy with sepsis secondary to possibly pneumonia who had a splenectomy, and it's your job to recognize that he's got an infection, your job to recognize that he's immunocompromised from a splenectomy, and which vaccine should he have gotten to kind of prevent this condition. So I wrote presented, I apologize, it's prevented. So the PCV13 vaccine, so the pneumococcal vaccine could have prevented this. Another kind of learning point, kind of general learning point about next best step questions like in management is number one, we already kind of mentioned this, but look at the vitals, okay? Look at the vitals, right? ABCs in medicine always come first. And I'm a third-year resident physician. It's still ABCs to this day. Every time you see a patient, the first thing that comes to my mind is, okay, are his ABCs intact, right? His airway, is he protecting his airway? Is he breathing on his own? And C, circulation. And so he's breathing just fine. It sounds like his mental status is fine, although he looks kind of sick, but he's quote unquote protecting his airway. So he doesn't necessarily need to be intubated. Breathing sounds like comfortably, and they're not saying that he's requiring a ton of oxygen to keep his saturations up, so his breathing is probably okay. And then circulation. So his blood pressure is 110/60, which is fine. It's normotensive. But let's say his blood pressure was 70/50 and he was hypotensive. Now, that would certainly change our answer, because even though antibiotics would still be correct, before the antibiotics, I want to get some fluid in him, some IV fluids, to bring his blood pressure up. So, if his blood pressure was 70/60, the answer would change from antibiotics to fluids. And you must be thinking, well, that's so silly. He needs both. But again, it's saying next best step. So fluids and then antibiotics. In reality, you're just doing them all at the same time. But ABCs first. Another kind of general principle that works most of the time is if the patient looks sick, treat first, then diagnose. Okay. So, you know, kind of going back to our example of, yeah, this guy probably needs a chest x-ray, and would a CT be reasonable for a guy who's got a terrible pneumonia, maybe he has a pleural effusion that needs to be elucidated? Sure, you can make an argument, but he is sick enough to me that he needs to be treated before we should diagnose him. So looking at the acuity of the situation will kind of help you figure out, should we do a diagnostic test first or a kind of treatment modality first? Okay. So the answer is antibiotic therapy. I think it's a fairly straightforward question. There's a lot of good learning points here. And let's do another question. Let's do an easy one. Let's go to the stem, or the last sentence of the question. Which of the following is the most appropriate next step in management? So it's another management question, which is great because we're doctors. We want to manage stuff. Next best step in management. So 70-year-old man, so pretty old guy, comes to the clinic because of a 3-day history of fatigue, dark urine, decreased urine output, and mild pain with urination and a low-grade fever. Okay, so quite a bit of constellation of symptoms here. And you're going to have questions like this where there is just so many words and you're just like, I don't know what's important and what's not important. What I would say is the least important thing in this is fatigue. Fatigue is not making you change your mind about any of the right answers. Like, oh man, I don't know if this is X, Y, or Z because this guy was fatigued versus he wasn't fatigued, right? But it sounds like he's having some sort of urinary issue for 3 days, so kind of an acute presentation. Okay, he's got a little bit of a fever, pain with urination, and some dark urine and decreased urine output. So pause the video for a second and just think about what the diagnosis is, right? Really, in medicine and in questions, really one line will tell you all what you think is going on with this guy. So go ahead and pause. Okay. So next sentence is his past medical history. He has gout, hypertension, and osteoarthritis. His medications are allopurinol, hydrochlorothiazide, and acetaminophen, or Tylenol. Interesting. Temperature is 37.9, so kind of a low-grade temp, not quite a fever just yet. Pulse is 88. Respirations are 24, so he's a little tachypnic. Blood pressure is normal for an old guy, or a little high. Pulse ox shows an oxygen saturation of 97%. That's normal. Jugular venous pressure is 7 centimeters of water. Normal. Cardiopulmonary exam shows no abnormalities. Which of the following is the most appropriate next step in management? So, this question can go a couple different ways here. But I'm going to tell you how I break it down. So 3-day history is an acute presentation. Decreased urine output, mild pain with urination, and a low-grade fever. What I am seeing in this guy is he probably has some sort of urinary obstruction that has led to UTI. Okay, and it is not common for males to get UTI, but elderly gentlemen, if they have an enlarged prostate, as the urine backs up behind the enlarged prostate and you can't get all the urine out, bacteria can ascend and cause infection. Okay, so that's kind of where my head is going with this guy. Which of the following is the most appropriate next step in management? So discontinuation of acetaminophen therapy. I don't really feel a certain way about this answer. I don't think acetaminophen is affecting his prostate or his genitourinary system or his kidneys, so it's kind of irrelevant. IV administration of fluids, pretty good answer. C, measurement of post-void residual, also a decent answer. And then D-oral trimethoprim sulfamethoxazole, or Bactrim, which is just an antibiotic, and then E, renal biopsy. So renal biopsy, first of all, I don't think this guy has a primary kidney kind of issue. This seems like a urinary obstruction leading to UTI. So for him, what I would want to know is, the first thing I would want to know is, what is the reason for his decreased urine output? Is the reason for his decreased urine output, why, right? And so the two best answers for that are B and C, fluids or measurement of post-void residual. The reason the answer is C is because if he's very obstructed, right, if he's got an enlarged prostate and his bladder is super full, well, we can fix that right away. So essentially a post-void residual is have the patient try and urinate as best as he can, and if he's got an enlarged prostate, he'll only be able to dribble out, a few cc's. And then, this is something a nurse can do, or you can do. Just put a small ultrasound on his bladder and you measure how much urine is in the bladder. So different hospitals and different systems have different cutoffs, but I would say anything greater than 500 cc's on average is a positive post-void residual, and the patient has urinary retention. Okay, so before you give fluids, I would want to check, hey, is the cause of this guy's decreased urinary output, is it just urinary retention that led to UTI? That's an easy fix. That's just a couple of minutes and you can figure that out. So I would measure the post-void residual. If it's high, this guy would get a Foley catheter or a urinary catheter. Antibiotics. Antibiotics are a good answer choice, but they're not the perfect choice because, again, this guy probably has a UTI, but what's the point of giving him antibiotics if you can't control the source? And one of my attendings for the last 3 years has told me, and all of our residents, is, hey, what's the best antibiotic? Well, it's source control. And that means putting a Foley catheter in him so that infected urine can drain out nicely. And then you could give him antibiotics. So putting in checking the post-void residual, eventually putting in the Foley catheter, and then starting antibiotics and probably giving him fluids. So that's the video. We did a couple questions. We will do 1 or 2 questions every day and analyze them. Please drop a comment below what you'd like to see next. If there are any changes, if you have any suggestions, I'd love to hear them. And this I'm kind of doing for myself to help me study a little and help others study. So thanks so much. Have a nice day. Bye.